Thank you for joining the OTEP clinical case webinar. Our first topic of the year is coming off OAT, presented by Dr. Mark Hardy, who is the Director of Medical Services at Drug Health Services in Southwestern Sydney. We're really lucky to have him join us tonight to present this topic. We have a lot of interest, and I know it will be very interesting, and we have some questions for the audience throughout the presentation as well. I'd like to begin by acknowledging the traditional custodians of the country on which we meet and recognize their continuing connection to land, water, and culture, and also pay our respects to elders past, present, and emerging. So these are the locations of people who have registered for tonight. We do have a lot of people joining from other states, 24 people, as well as representation from every LHD. Thank you very much for joining. And also the specialties and roles. Again, someone from every role. We have a lot of general practitioners and pharmacists who are joining us, as well as a lot in addiction medicine and psychiatry and nursing roles. Thank you to everyone who's joining tonight. For those who have come before, you may already know this information, but for any newcomers, the OTEP clinical case webinars are monthly webinars held on Tuesday nights between 6 to 7. These webinars are recorded, and the recording is available on the OTEP website under the webinars tab. For those who are joining live, we will email a certificate to you that you can use to claim CPD points for. And again, if you want to revisit the webinar, you can look on the OTEP website. And some quick housekeeping before I turn it over to Dr. Hardy. Please keep yourselves on mute. If you have any questions, please feel free to type them in the chat. We have Dr. Sharon Reed with us who will monitor the chat and occasionally interrupt Dr. Hardy to ask some questions. It would be great if you can introduce yourself before you ask a question, but not necessary unless you'd like to. And again, the webinars are recorded, so please don't reveal any identifying information. And yes, I'll turn it over to Dr. Hardy, so I'll stop sharing my screen and let you share.
Everyone comes from different lands. Principally, I'm in Eora at the moment, but I work in Dharawal and sometimes Gandangara. People work all over this beautiful country, which has never been ceded, and we hope never will. And we want to also acknowledge those elders past, present, and emerging who are here with us today. I also want to acknowledge people with lived and living experience of the problems with which we share and discuss and talk and illuminate each other, and hope that we can bring the knowledge that we share to improve our lives and those of us around us, or those around us. So I always do 3 talks, as people know, and the talk I wish I gave is the one that I give afterwards. The talk I give is the one you're hearing, but beforehand I also think about what am I going to do with the talk. So I try and lay it all out in an executive summary for you, so you've got some idea of how this is going to traverse during the day. I can say the word traverse because the Winter Olympics are on. That's good, isn't it? So we'll talk about, what did I see as the goals of OAT when I first started prescribing, and how was it explained to me by experts when I didn't know anything? Because I think that's really good. And I think assuming a different knowledge base individually between the entire audience gives us that opportunity to find some common language and ground. Then we'll talk about the boring stuff, some national and state-based statistics, who's coming, who's going, the demographics that might have changed over the last 10 or 15 years. I want to talk a little bit about expectations of treatment because I think they vary between clients and clinicians. And then we'll go on and talk about exit types, voluntary versus involuntary, and the sorts of implications each of them do. Briefly, just a slide or two on some challenges of OAT, and then a slide on some outcomes Questions, they're not my questions, they'll be your questions, although they may be dotted through the talk rather than just at the end of the talk. If anyone can't hear or there's a technical issue, put it in the chat, and Jessica or Sharon will bring it to my attention immediately. If something isn't clear, by all means, let us know. Um, so obviously when I did my very first course, which at the time wasn't called OTAC or OTEP. In fact, I'm struggling to remember what it was called. It wasn't clearly laid out to me, apart from perhaps perhaps one or two of these elements, what it was that we were trying to do when we were doing what we were doing. But there are really three simple goals of OAT for our clients and community. The first is symptom relief, and the second is the loss of secondary gain and reward from using, and the third is providing people whose lives may have become chaotic with some structure and feedback so that they can grow both into the program and into their own lives. So symptom relief involves things like managing their immediate withdrawal, and this helps enhance engagement. It may reduce cravings almost immediately, although we also are coming to understand that cravings are a nefarious beast and they can come and go throughout the lifetime of a person. The second main tenet of treatment is the reduction of reward from substance use. And with methadone, this was done via induction of tolerance. We found, though, that mu receptor occupation using buprenorphine provides a slightly different mechanism and a quicker run towards the reduced reward because of its strong binding affinity and long half-life. However, over time, it also induces tolerance. Uh, and the third thing is the combination of those two elements prevent overdose. If you ask an addiction clinician what is the primary purpose that they get up in the morning, they may be able to run off 10 or 12 things very, very quickly to you. But I think primacy would be prevention of overdose. We want to keep our clients alive and safe long enough so that they can make decisions about what they want to do next with their life. Then the third major tenet of treatment is structure and feedback. So the invisible elements of the program, the things that we do that might not necessarily be a medicine or be a piece of advice, but over time, it all adds up. Shared management plans, providing people with appointments, providing them with some certainty, some transparency, your drug screens where appropriate, counselling and therapy, monitoring for slip-ups and relapse. I won't read off every slide, so don't worry. Though I did that a little bit. I think I might have got away with it, but I'll try and talk about the slide rather than reading it, because you'll all have an opportunity to get a copy of these later. If we look at the Australian Institute of Health and Welfare, they take a sample day and they measure. They measure a bunch of statistics about OAT programs. The average across Australia was 21 per 10,000 people. It still amazes me how every statistic that is relevant in public health is per 10,000 people. We don't do it per thousand or as a percentage, but it has become the international standard. New South Wales has the highest number. I'm not sure if that's because we have more people who require the treatment, or it may be that we have a different access pathway that facilitates that sort of number, and an availability of treatment spots. The lowest was in WA. Northern Territory was not far above WA. There were some figures that were difficult to track because, and I haven't got the graphs unfortunately, because there are many lost years during COVID. I think this slide indicates that people are getting older in treatment, and the median age across all pharmacotherapy types is now 46 years, and older in some jurisdictions. Interestingly, I don't want you to sit there and try and read everything that's in this slide at the moment, but what I do want you to know is there are less people who are presenting under 30 and more people presenting in the 50 to 59 and 60 and above age group. This also demonstrates not just a changing pattern of age, but a changing pattern of substance of concern. But there are some other reasons, and this is a bullet list of some of them. Obviously, OAT has been around for a long time now. And it does reduce the risk of premature death. So we're seeing this population age. And this means people are seeking treatment in older age. I think regulatory changes to the way we deliver other analgesic medication has also driven up the numbers of older people presenting, those who are on pharmacological opioids and unable to stop, or for whom they've become ineffective and pose a potential risk to their health. But also the population in general is aging. The boomers are retiring, and pretty soon we'll be seeing Gen X retiring at some stage in the next decade. It'll be very interesting to watch how that pans out. Um, it's interesting when we look at gender, more males than females, about 2 in 3 were male. The third classification, another term other than male or female, was not introduced until the 2020s, which I find really surprising, actually, that it's taken that long for statistics to be collected on that. And there is a peak of people who were receiving pharmacotherapy, and that is different from the mean. It's sort of the median age, about 44 for males and 46 for females. What are they taking? Well, now they're more likely than not to be taking buprenorphine. Methadone is still a very, very strong contender. Uh, it is a drug like its clientele that is aging. There are less new inductions to methadone, obviously, than buprenorphine, given that buprenorphine has only really been around in this country for about 25 years. Um, in terms of people and their destination, over half, nearly 60%, were ongoing treatments. New treatments were only about 17%, and those re-entering treatment who hadn't been in treatment was around about 9%. It's interesting that the last bullet point there, a third admitted using heroin, another third pharmaceuticals, and another third not clearly stated. It surprises me that we don't have better data on that other third, because I would have thought that most jurisdictions would ask what was the opioid of most concern, or even the series of opioids. Some people, though, may not even know what their opioid was, particularly if they were buying things on the dark web or the black market. So let's get down to business and talk about exit types. There are really four key pointers that I want to cover with exit points: voluntary versus involuntary exits, informed consent for planning and a voluntary cessation of treatment, the implications of involuntary cessation of treatment, and the reasons for exit. Um, Now, when we talk about voluntary exits, we can talk about early versus late discontinuation. And early really is a failure of engagement. It's in the first few weeks of treatment. People are unable to stabilize and they can't manage to get to the goal of a safe dose or abstinence or decrease use to the point where they feel that's where they wanted to be with their treatment. Late discontinuers, on the other hand, have a myriad other types of motives for coming off. Usually, this is well after target doses have been achieved, and the outcomes may already have been realized in that they may have had 5, 10, or 20 years of stability. They are a chronic dosing scenario. They're looking for life beyond their opioid agonist therapy. This group usually don't discontinue rapidly as compared to the early discontinuers. They gradually taper. They usually are accompanied with a plan to remain off opioids longer term. Um, and obviously, there may be other motives for it. They may be moving to another area. They may be moving internationally. They may be retiring, and they want to retire their opioid treatment at the same time. When we look at retention versus dropout, which is, I don't really like the word dropout. I prefer the word discontinuation. So, but I'll put it in the heading, but I'll try to desist from using the word dropout during the rest of the talk because it does sort of connote failure. And I don't think that's really the point here. I think the point here is discontinuation for what people at the time saw as valid reasons. One of the good things about OAT is that about 70 to 80% remain engaged in the 6 to 12 months in structured programs. And we see this internationally in literature as well as in Australia. Discontinuation, though, is commonly reported. Just going to reduce the screen so I can see everything within the first 6 to 18 months. And early discontinuation is unfortunately too common. Um, and it can be a quarter to nearly a third of people who discontinue. If we look across the broad literature, most discontinuations in the first 6 months probably happen in the first month or two. It's unusual once people get their doses increased and the number of reviews that occur for them to discontinue suddenly after 3 months. I'm trying to make this interactive. Here we go. Clients of a younger age, still active in addiction with poor psychosocial history, should be encouraged to remain in treatment if they can. It's good to see that answer. Answer's coming up.
And I'll let the poll run for another like 10 or 20 seconds, and then I'll end it
Yeah.
and share the results.
Yeah. So yes, this is correct. They should be encouraged to remain in treatment. And I'll move on to the next slide. I'll just take this off. And did everyone see that? Just Jessica, with that right?
Yes.
So, good. Yes. So the answer, yes, is true. Okay. All right. So why did I ask that question? And every question obviously will be will predicate a slide that explains the evidence. And the evidence is strongly against people leaving treatment voluntarily early. So a number of studies demonstrate that that under 25 years, but particularly under 19 years, this is not a great time for people to leave treatment. In fact, Dr. Jason, Hayder Jason, who's an advanced trainee in our service, coined a phrase. Unfortunately, it doesn't exist yet in the literature of treatment resistance and poor OAT response. And I really like that statement. So this, I've put him as a co-author because some of his slides were so good that I couldn't leave them out of today's talk and deny the rest of the world the chance to see the way he's summed it up. So, ongoing substance use, drug dealing, non-fatal overdose, another poor predictive factor for relapse. People with untreated mental health comorbidities or unmanaged or partially managed. Those with significant social instability, including housings and other social goods, and the whole group of populations which are marginalized and stigmatized, and those whose first 2,000 days of life have been very, very poorly managed or poorly lived, including Indigenous populations. Um, um, it's really important for them. And the rules-based program around liquid handcuffs possibly shouldn't be in this slide. It may be a slight editorial mistake, and I may come back to that later. But some people will push back against an OAT by describing it in that way. And I think it's a bit unfortunate and a little bit unfair if early in treatment, that's how people feel. And I think that's one of the things that we have to get people through in the first couple of months of treatment in order to get them to the next level. And the last bullet point confirms the bullet points above. Question 2, here we go. Clients with a poor treatment response may exhibit the following characteristics. Persistent illicit opioid use despite adequate dosing, ongoing craving and instability, failure to stabilize or retain engagement despite appropriate delivery, all of the above. No surprises there. All of these things are bulleted in the next 2 slides time. I think you can pull that down if you like, or do you want me to pull it down?
Yes, I've stopped that. You should be able to just go to the next slide.
Hit X. Right, we're back there. Here we go. Yeah, all of the above. Okay, defining treatment resistance. As I said before, and as Dr. Jason reminds me, there's no formal DSM definition of OAT treatment resistance in clinical practice. However, it is best conceptualized by a number of very important characteristics, which are all outlined in that previous multiple choice question. So people who can't stop using, people who have ongoing cravings, and people who can't stabilize despite what we think might be appropriate treatment delivery. And I say what we think because clearly what they think and what we think are different. So again, predictors of discontinuation are cravings and withdrawal, ongoing use, daily injecting behavior, recent release from custody, and poor treatment experience. And we know for a fact that this is markedly increases the overdose and mortality risk. And study after study has been done on the first 2 to 4 weeks of people after prison and what happens to them. And the mortality risk is manyfold increased over the baseline for people who are stable in treatment or have never used a drug. Now we'll talk a little bit about late discontinuation. So long-term stable dosing is usually a deliberate managed plan of deprescribing. It's often associated with feelings of closure from an episode of care. As I said, people may be coming to a point in their life where after 5, 10, or 20 years, or as they change jobs, move into state, retire, they're retiring from their job or they're retiring from a situation and they want to try and retire their OAT as well. There are other things. This is the liquid handcuffs moment. They may feel a lot of restriction in a program. Traveling to some countries may be difficult. Uh, I believe you can actually take a small amount of your own buprenorphine to Japan now, but don't take my word for it because the legislation may change. But I did have a case many years ago where someone wanted to go to Japan with their OAT, only to be told by the consulate that that was not possible. There are other countries. I've had someone have their OAT taken from them when they were trying to enter the Russian border about a decade ago. And they spent 7 days in detention and were flown home. They were very sick when they got here. The other one, of course, is stigmatization over the lifetime. So what does it look like? Stigmatization can be really obvious. You come to hospital, you're having a knee replacement, you tell someone you're on methadone, and they start to change their demeanor with you. It may be that that you're in the post-op ward having had your knee replacement and you ask for analgesia, only to be told that the methadone you're having should cover it. It can be going to the chemist and waiting an extra 10 minutes while 5 people are served in front of you who happen to come after you. It can be that you haven't even told your life partner that you're on OTP or OAT because you're scared it'll end the relationship. It can also be driven by other things, negative issues such as incarceration and separation. The side effects of treatment are important cofactors in discontinuation. Central sleep apnea, loss of libido, loss of hormonal regularity, particularly testosterone, poor cognition as we age, and weight gain. Interesting, I'm seeing increasingly, particularly with this aging population, the chronic pain and palliative care scenario where people have been on either methadone or buprenorphine for 20, 30, 40 years, only to find that as they move from the community into care, such as a nursing home or a hostel, it becomes harder for them to access treatment. It's really important if you've got a patient who has been under your care for 20 or 30 years, it is moving into a hostel, and you're either a clinician based somewhere else who doesn't visit that hostel or doesn't visit that nursing home to give really good transfer of care for that particular client. It may mean that it's a like-for-like drug. They may, in fact, be an opioid prescriber themselves, so that would make things much easier. Or looking at alternatives that would be able to manage that situation for them on a day-to-day basis with your support. So I'd encourage people to think laterally when your clients are aging about what transfer of care looks like for them. There's talking about discontinuation. It doesn't seem logical that we shouldn't talk a little bit about retention in treatment. Obviously, we want to optimize doses where we can, and we want to make sure that if we're switching agents, we do it safely. Particularly if there is an inadequate dosing scenario with one medication, or there are unacceptable side effects. For instance, the classic QTC or sleep apnea scenario with methadone, transferring people to buprenorphine can be very, very helpful for that group. Some people with severe chronic pain, I've had a couple complain that despite what seems to be very adequate doses of buprenorphine, are looking for some other form of opioid management because they have been long-term chronic opioid clients. So it's really important to think in both directions, bidirectionally with this. And one of the most important things is if you are switching agents, to think about how you're going to do it. We now use a couple of different techniques to the way we used to do it. Obviously, microdosing with buprenorphine is a boon for getting people across from methadone or some other opioid. We're allowing them, particularly with very short-acting opioids, we see increasing numbers overseas of people addicted to fentanyl. We've had a cohort of individuals in our own district who are addicted to nitazines. To be able to transfer them over, one has to think a little bit laterally with them. Microdosing can help, or repeated dosing on a day-to-day basis can be helpful for some clients, and particularly the methadone clients. Microdosing and bridging dosing with another opioid may be helpful. And one of the other things we can look at for people who are struggling with retention in treatment is long-acting buprenorphine. It's certainly gotten great legs over the last decade in terms of improving retention for those who are struggling. When I first looked at LAIB, we were together, I think, as a cohort in addiction medicine, we were thinking this is going to be great for stable patients. They'll do a one-stop shop once a month, and that'll be fine. In fact, it's changed the game for the least stable patients because they are now able to access treatment for longer without feeling constricted as they might have before. And I think this is a real help, particularly with the early discontinuers. Clients often have short-term goals in OAT while clinicians think longer term. True or false? Let's just share that. That's enough. Yeah, it's about an 80-20 because some clients will be thinking long term. But we know clinicians will be thinking long term, but our clients, the answer is some are and some aren't. Okay, I'll click off on that and we'll move on, save a little bit of time. If it'll let me. Yep, and on we go. And that's exactly what you would think. You know, there's a proportion of clients who are thinking long term, but most of them are thinking short term because the day-to-day hassle of getting their shot or their hit or their medication becomes too much for them in the end, and they're on this constant sine wave, or this wave of intoxication versus withdrawal, then acquisition. And eventually the loss of resources leads them to having to come to us to help them. There may be forensic implications, and they may have had a near miss, or they have fear, or they know of someone who has unfortunately passed away. Whereas I think clinicians in general have been taught, and most of our training and most of the OTEP goals are to show people how to manage long-term problems. And chronic dosing, we know, is helpful with cravings and withdrawal, and it improves long-term engagement and makes a whole bunch of social goods such as housing, income, protection, and life possible for these people. It's really important. It helps us to reduce exposure to exploitation, and it clearly reduces overdose risk. But I don't know how well we all can prosecute that argument to people at the start of treatment when they're desperately unwell and they just want our help. And so when we are planning for withdrawal, we need to really think about assessing their stability and suitability. We need to have informed conversations about the risks and benefits. And we need to discuss in our own mind and with the client exit paperwork. Some people may still owe money at a pharmacy. They may still owe money if you're charging private fees. You've got to ask yourself, is it legal for you not to exit someone or transfer them to someone else on that basis? And the answer is it's not legal for you to hold on to them if they want to go because it's a voluntary program. If you or the pharmacist want to debt collect them, that's up to you. Okay. But that's a different matter from exiting the program. And if you tie the two together, then it's no longer a voluntary program because it is not freely given. You're using coercion to get what you want. And I don't think that makes a lot of sense here, and it certainly has no legal basis whatsoever. So you need to be open-minded and flexible. You need to you think about planning dosing schedules with your clients, uh, and you need to remind yourself they're voluntary patients. Be prepared to slow down or speed up depending on how they go, and also don't forget take home naloxone. I'll say that about 3 times. Don't worry, there won't be a question on it. So when it comes to reducing off methadone, clients probably need to go fairly slowly. As a moderate agonist with moderate binding affinity, um, it they will only be held clean from other opioids by their induction of tolerance. So you've made them tolerant. Therefore, as you bring their doses down, you can't bring it down quickly. And 5% to 10% per month would be an absolute maximum. Generally speaking, 5 milligrams a fortnight is, in practical terms, possible. 5 milligram per month is certainly reasonable. Uh, I've had people come down even slower than that. And certainly when you get to the end of it, each time you take a slice out, you're taking a larger percentage of what is left. And I have people under 20 milligrams who've got brilliant pharmacists that'll take out 1 milligram every fortnight for them or every month. But 2.5 may be suitable for some clients, but it may not be suitable for everyone. Think of that fourth bullet point. Everyone's different. It's very idiosyncratic when you're decreasing doses, and there's a tripwire dose for everyone, and it's not the same dose. Some people will suddenly feel unwell at 60 milligrams when they're coming off 100. Others might get all the way down to 30, and suddenly they say, "I have to stop, doc. I've had enough. I'm just going to need to sit here for a month or two." Others may be able to get all the way down, virtually to nothing, but be prepared to stall at certain doses and maybe even increase because they need to make sure that they remain stable. If you introduce uncertainty and instability to the situation, you're changing their suitability for this type of decrease without meaning to. And also monitor for use of on-top drugs. A lot of people think that the safest way to manage their withdrawal is to take something else. So be mindful that that could happen. Keep an open mind. If you need to do urine tests for this, obviously you should. You should be doing urine tests at a prescribed interval for everyone anyway. And be transparent with them, and they will be transparent with you. Buprenorphine, again, similar. Don't worry about the bottom 3 points. They're identical to the last slide. But again, consider reductions over months, not weeks. Some people can move quicker because of the way buprenorphine works. But in practical terms, for someone who's been on buprenorphine for a couple of years, they are going to be tolerant as well, and you will need to go very, very slowly. I've given some examples there of how to do it. There is no set recipe with it. When you get down to very low doses, you may want to keep people on a bute mono for a little while and see if you can get them off that way. Again, be prepared to re-establish stability with dose increases or dose stabilization. Unfortunately, with LAOB, we don't really have a lot to go on. Again, we can set monthly dose reductions. And as I said before, LAOB is the classic chronic dosing scenario. We think of it again as a long-term treatment. But I have a number of clients on 64 milligrams who are wondering, well, what's going to happen next? And the answer is we haven't necessarily got an answer to that other than potentially putting them onto films plus or minus tablets. And so, again, there's a lot of uncertainty about this, and that this is a classic example of using some poetic license. Obviously, don't use less of the 64 milligram injection because you won't know from month to month whether you're giving them 32 milligrams or 64 or 48 or whatever. Don't use a weekly injection instead of a monthly injection because it's designed to last a week. It won't last the month. Another common misconception, I guess, that came with the LAB wave that when it first came out was we can use this as a detox drug because their doses their blood level will decrease slowly over time and they should be able to have a soft landing. Unfortunately, it's not like that. And receptors are occupied to a certain extent to prevent cravings, but once a percentage falls below what is considered enough in an individual. We like to think of 80% receptor occupation as being protective for people and 80% above. But there is a number well below that where people literally drop off a cliff. And unfortunately, it's not a linear thing with LAIB. So a few little warnings there when you're reducing people off that. You just cannot stop it and then let them have a gentle soft landing. It's likely to be fine until about week 5 or so if the doses are usually holding them for a month, and then suddenly withdrawal ensues, and you'll have to manage it again like you'd manage any other withdrawal. Okay, question 4. When consenting a patient coming off OAT, it is important to warn them about the risks of relapse, decreased tolerance, overdose, and death. True or false? So the answer is true. Yep. Well done, everyone. Told you there are no red flag questions here and no tripwires. So what do I do when I'm doing informed consent? What do I write in the notes? And potentially, if need be, what do I get them to sign in the notes if we're using written notes? Obviously, it's harder with verbal notes. People are now using generative AI in notes, so the patient's consent can be recorded into your clinical notes if you're using a generative AI with your practice software. And those are the things that you have to warn people about. The exact things are in the question. Um, Unfortunately, what happens is as we decrease people's doses, we do a couple of things. We decrease their tolerance. We reduce the receptor occupation, which may increase cravings and withdrawal and lead to an increased likelihood of relapse. Unfortunately, low tolerance, strong opioids, is not a great combination, and respiratory depression and death can follow. Again, don't forget, take home the Loxone and remind people and show them how to use it if necessary. I think if they don't know, you should be showing them. Again, remind them that if they require dose escalation or reinduction, your door is open at any time. So what are the predictors of success? Again, I think we touched on this a little bit earlier before. A stable patient who's got a good understanding of things, how things are going, what you're going to do to them, how you're going to do it, and why we're doing it, that they've got psychosocial support and regular reviews. Regular reviews, really important. If we can, we don't want unstable or problematic use of alcohol or other drugs. If someone says to you that they're having uh, one standard drink on a Friday or Saturday night, that does not automatically disqualify them from having a reduction in their opioids. But if they have had a previous problematic use of alcohol, and they're still struggling with alcohol while you're taking them off opioids, you could probably expect to see more of the same, more alcohol that is, while they're coming off because they're trying to swap out one dopamine inducing drug for another. Stable mental health, really important. Stable social conditions. There is no time, by the way, that we can say for sure that is the right time. It's individual, but I wouldn't think it would be less than a year or two to even think about it in a first time individual. And again, it may be that for a lot of our clients, they don't ever come off. The vast majority might never come off, but there will be some that will attempt and some who will succeed. Question 5, involuntary discharge can be done without discussion during, which includes the OAT client. So in general, the answer is false. And I won't go into, I haven't got a slide on the exceptions, but I can see that there are some people who say that it's true. Um, uh, it shouldn't happen. It sometimes has to happen. But in general, I would say that it should always be a collaborative scenario between and I've written false, although I'm happy to be challenged on that answer. If someone actually completes an assault on someone, or whose threats are so compelling that they are unable to be ignored, there may be a case for involuntary discharge. But in general, I think we need to think about this logically and rationally. It's an irretrievable breakdown, obviously, at some stage between the client, prescriber, and/or dispenser, and it should be a last resort. Um, and again, there's opportunities when people calm down and the smoke clears to think about, well, is there a better way? What about a transfer to either a public clinic or another prescriber? Is there a third option other than staying in the treatment or leaving the treatment, with yourself, that is. Um, and I think you need to exhaust those options, even if it's just a checklist that you're going through in your own mind, that have you thought this through before you're doing it. And I think where possible, and that's 95% of the time reflective of the answer that was given, or more than 95% of the time, there needs to be some sort of discussion with the client at a later date. If the client's given you consent to discuss it with next of kin, that would be a second option, possibly not the best option, but an option nonetheless. And I think at the end of the day, if you feel that you're being stigmatized and you're the vulnerable person in this dynamic with the client, then you, we need to try and remain clear and respectful with our communications, because we actually hold the position of power. And there is a disproportion of power, and sometimes the irretrievable breakdown is because the clients recognize that, and they're not happy about that. Again, you can't get someone to sign a consent for an involuntary discontinuation of treatment. It's incredibly difficult to do because by its very nature, it's involuntary. So look, again, let's going back through the annals of time, thinking about why people leave treatment involuntarily. It's not all covered in the treatment agreement, but a lot are. There's a list: violence, property damage, criminal activities on or near premises despite warnings, or use of the services and the premises for purposes beyond those. So criminal activities might include theft, drug dealing, um, uh, uh, other malicious damage, things like that to property that might not necessarily be your property. Use of the premises may involve people who decide to set up a business inside your clinic, and not just soliciting. They may actually be involved in some other legitimate business, but it's inconsistent with the values of a clinical practice or a clinic itself. So you can think about various things that might be. Now, this is a very busy slide. Again, don't try and memorize it, but there are some legal implications of involuntary cessation of treatment, and you need to really think about, when you're doing a treatment agreement, you need to think about involuntary cessation. There's no point thinking about it later, after the treatment agreement's signed. So it may be helpful in some treatment agreements to include examples of why people might be asked to desist from coming, or asked to leave the clinic. And again, then make sure that that treatment agreement is signed free of coercion. Obviously, some people will be signing it because they're desperate to get on treatment, but you need to make sure that they understand that this agreement is a really important part of their treatment. And again, that's that third part that I was talking about before at the start. Symptom relief, induction of tolerance, and reduction of reward. And the third thing, structure and feedback. The treatment agreement holds that third part within its arms. Again, you can't go back and change the treatment agreement unless it's by mutual consent. Um, Zero tolerance doesn't mean zero chances. That is, if you can still put a zero tolerance when someone swears at you or bangs the desk or says something that you find offensive, um, and you can remind them of their obligations under the treatment agreement as you are trying to execute your obligations to them and your duty of care. Um, and of course, remember that that if you do that, you've got to redirect them back to the agreement. You might need to provide them with another copy of one and ask them to rethink about things, maybe go away, calm down, or book another appointment at a later date and see if clearer thinking can prevail. Involuntary treatment is also, a discharge is a transfer in itself to the community. That is, you're taking someone off treatment over a period of time, and you need to hopefully make sure that people are informed that this is happening, where consent has been given to inform people, such as referrers and carers. Um, don't forget that privacy of this client is as important now as it was when they were complying with everything that you wanted them to comply with. And it is a basic human right and is not waived by an involuntary discharge. It should be strictly observed, even in death, unless you have a legal imperative to disclose something of their privacy. You just can't do that. Of course, negative outcomes may occur. Not all of them have been tested in court. So make sure you document everything you can. And again, don't forget, take home the naloxone. So rather than, I think we've still got a few minutes, and these are the challenges of OAT cessation, symptom management, the clinical complexities of people with comorbidities, and the psychological barriers. Okay, question 6. Benzodiazepines are the best symptom management for clients coming off OAT. True or false?
Mm.
Share that. Yeah, good. Well done. The answer is false. I gave you a whole bunch of true ones and then I threw in a false one. Here we go. Okay. So it's a multimodal management. Symptom management with purely with sedatives and hypnotics is not generally recommended. And certainly when you get people to subtolerant doses, that is, they're getting down below doses of induction, and they're using illicit opioids and benzos on top, which will lower their overdose threshold. Um, they can get themselves into real strife. And I've seen people pass away in this scenario, so be careful. Um, uh, and that if there is an option for residential withdrawal management, it might be an opportunity with that group to do it because they're showing some complexity, and their suitability for going on with the withdrawal management is starting to slip. In terms of symptom management, obviously, there are lots of great symptom relievers for nausea, cramps, GI upset. Some people rely on different supplements. I'm not going to tell you which ones are best. The answer is everyone's different, and I don't know what's going to be best on your next client, but there's a few that I've seen that people use. There's limited evidence for mood stabilizers and antidepressants, but that doesn't mean that you shouldn't use them. And some of our clients need to be on them anyway. The psychological comorbidity rate in OAT patients is somewhere between 50 and 80%. I know it's quoted as lower, but I did a chart review in Northern Beaches when I was working at the public OAT clinic there. And we found that Axis 1 diagnoses were well over 50% when we were using DSM-4, and the Axis 2 diagnoses were about 80%. So they may have needed to be on some form of treatment even prior to considering dose reduction, and that needs to be stable. But some mood stabilizers and antidepressants may be helpful if they're introduced early enough before people actually start to feel the changes of their doses. And finally, I think psychosocial interventions are really important at this stage. People need support, need to make sure that if they're disintegrating socially, that you suspend the withdrawal and get them more support, and then go back and think again whether or not to continue, or save the withdrawal management for another day. Quickly, some things on chronic pain and comorbidities. So the chronic pain patient, I think it's important to remind them how they got here with you in the first place. They may have started out with a pain medicine and ended up being unable to use it appropriately, or it no longer having any benefit for them, or the doses just being so high that they can't be prescribed. Three things can happen when you start to take them off that are things that aren't helpful. So they may get rebound effects from the reduction or cessation of their opioid. They may obviously get withdrawal symptoms. They may relapse in terms of the amount of pain they were experiencing before they had opioids in the first place. Consider using opioid sparing medications if you can. So long as, again, with caution, some of them have a risk of dependence. Even the gabapentinoids can induce tolerance and eventually dependence, and they are not a suitable replacement on their own for people with chronic pain. And the chronic pain population may struggle to get off opioids completely because they're so neuroadapted to them, and they may not be able to manage without them. There is, again, some work done in the cannabis space around opioid sparing qualities of cannabis. It remains controversial. It's very difficult to do RCTs due to the ubiquity of cannabis in the community, both illegal and legal. And again, another example of what not to do is to just rely on one drug for these people, such as cannabis, to help them coming off opioids. Although a lot of them think that's the golden solution. Again, with this clientele, the dose reductions may need to be tapered down a little bit, and they may need to be less, and the tapering may need to be longer. Again, they may be long-term opioid dependent, and these clients are the sort of ones you don't do at home alone. You ask for help, specialist advice, and supervision. Other clients, of course, are reminded of a time when they couldn't get a shot or that they were late for dosing and they weren't dosed for a day and they went into withdrawal. And so a lot of clients are fearful of withdrawal and fearful of relapse. A lot of clients remember when they couldn't get to a chemist over a long weekend and they had to have an illicit form of their opioid. And they felt a lot of shame, guilt, stigmatization as a result. And so when you start to talk about change with this group, they can become quite fearful and can recoil from it. I think this is a really important time to use your communication skills and to talk around that episode that they experienced. Don't hide it under the carpet. It's the elephant in the living room. It needs to be discussed, and then you need to work collaboratively with these clients on how you're going to do the reductions to limit or minimize the withdrawal, and provide them with whatever other safe medications and safe counseling and therapies that you can to afford them the opportunity that you're presenting them. Frequent reviews and pauses in dose reduction may need to be required. And as we talked before, medication and specialist advice can help. Question 7. Most clients can self-taper without much supervision and remain abstinent after coming off OAT. True or false? Sharing the results. Yeah, correct. I'll hit stop. I'm trying to make sure that we get through your slides. We're near there. We're nearly there. Don't worry. Okay, outcomes. So this is the only slide that didn't come with a question. Remember when we talked about consent, the relapse rates are really high in this group. It doesn't mean that everyone will relapse. I didn't present a case, but I had uh, a wonderful client of mine, a trans client, and she was on methadone with me for many, many years, and she had HIV, and it got to the end. She, in the last 12 months of her life, asked me if I would help her come off OAT with a view to what was coming next. Over the course of 6 months, she managed to get her dose down to 0. We met every month after that until she was too sick to come to see me. She passed, having not relapsed. Um, I didn't hear much until I ran into her sister about 12 months later, and she said to me that this was the most wonderful achievement of her life, and thanked me for the bit that I did to help her get there. She felt that she died with her dignity completely restored on her own terms, uh, in much the same way that life had been given to her. So even though you might think that that 10.8% indicates that it's not worth the journey, for some people, it's the whole journey. It's everything to them. And I've never forgotten her, and I never will. So the best evidence of success, of course, from Cochrane and others studies is slow dose reductions and slow taper. And it's underpinned by regular reviews, psychosocial support, and flexible tapering strategies. For some people, residential rehab may be required, either when they're tripping up or towards the end of the taper, so that their early abstinence can be built upon with some structured therapies, group and one-to-one, as well as some time away from temptation, if you like to call it that. I think we've got to the end of the talk in one piece. And although I didn't write a case, I think the case that I gave you was compelling enough to remind you that although there's only a sort of like about a 1 in 10 chance that you occasionally in life come across that one. And I think it was a really lovely experience for me to know that someone came to me and spent the last 10 years of their life with me, but the last year was the thing that really packed the biggest punch and gave the most meaning to their life. Okay.
Thanks, Mark. There's just one couple of questions in the chat or comments, and Marguerite says, "Love the idea of the tripwire dose." So true.
Yep.
And if you can answer this in like less than 30 seconds, how to handle benzodiazepine use on top of OAT?
Yeah. Oh, that's a great question. And look, there are some people who've, no matter what we do, so OAT doesn't make everyone not have pain, and equally, it doesn't make everyone not have anxiety. Again, I think if you're a solo GP in a practice and you feel like you're being um, asked to do something you don't feel comfortable about, get a second opinion. That's the first thing, if you feel you need it. Now, it can be done as easily as a phone call in the initial, but if you want at some stage to get a more formal structured review, addiction specialists at various LHDs provide these sorts of reviews for clients. Some even have a GP advice line, which is really helpful, such as ours at Southwestern Sydney. We service our GPs with some advice, and occasionally they come in for reviews. They're triaged into seeing one of our specialists or our advanced trainees. Um, the nuts and bolts of it is that if they can't come off their benzos, and you've taken those steps to get appropriate advice and it's documented, that again, a slow taper of benzos may be required with a stage supply. There will be a group who won't be able to stop de novo or stop permanently forever. They may require small doses of benzos in stage supply. And what does that mean? For some people, it may mean daily pickup. For some people, it may be a week supply. Uh, and in that group, again, you may want to get occasional reviews, no less frequently, I think, than annually, with a specialist colleague, and have something in writing in case they suddenly ramp up their benzo use and you find yourself in real strife. Again, there are other options. If they're keen to stop their benzos themselves, residential rehabilitation or a detoxification, most of the public LHDs will take people on OTP for selective detoxification. They may have to wait a little while, but wait times are generally less than a fortnight in most detoxes. It's rare to see them beyond a month. And we can look at doing selective detoxes or at least get them down to a dose that can be managed in the community, and the dose reductions continued slowly in the community with feedback both from yourself and one of our colleagues, one of our specialist colleagues.
Great. Thank you very much. And thank you very much from everyone in the audience for coming along and hopefully learning a lot from this presentation.